This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Our first speaker is Chip Gresham. He is a valued guest from emergency medicine and medical toxicology. He's originally from the US, but gladly for us in Auckland, he's gravitated to Counties Manukau or Middlemore Hospital in South Auckland. He is going to talk to us on a subject which is very close to my heart, and that's poison purification.
I guess if you're wondering where all the ADHD kids are at this conference, it's in this room. Glad to be a part of this, and as I said, I'm Chip Gresham, one of the emergency medicine physicians and medical toxicologists from Middlemore. Do want to talk briefly about poison purification and the role of an elimination enhancement, and basically multidose activated charcoal, urine alkalization, and extracorporeal therapy removal. If you've read the tox literature recently or at all, you know that we're very limited on randomized controlled trials. What we're left is case reports. Case reports, have the reporting bias. They're tough to make judgment calls off. There's a lot of just ad hoc treatment, and what we're left with is guidelines, consensus guidelines from professionals that kind of help us do what we do. And sometimes it's when to make the decision to do something. Sometimes it's don't just do something, stand there. So we're going to take a look at briefly a few of those guidelines. How do we move this on? Perfect. One of the first ones is the guideline for multidose activated charcoal. It's from the U.S. Academy of Clinical Toxicology and the European Poison Centers. They've basically combed the literature, looked at all the animal studies case reports, and got a group consensus on when to use multidose activated charcoal, the charcoal every 4 hours for an extended period of time. And they've come up with five things that's remembered by the mnemonic ABCDQ, and you can read these here. The only one that's really going to affect our practice that we see often is carbamazepine, and I do want to talk about that just for 30 seconds. It's, as a guideline, it suggests that if you have severe life-threatening poisoning, you can consider using multidose activated charcoal, and that's a lot of suggests and considers, but that's what we're left with. So what it should sit in your head of multidose activated charcoal is if you have a vented patient after a significant carbamazepine overdose, I'd consider multidose activated charcoal, and not before. There is a recent study down there in the quarter. It was a prospective study of 12 patients. They did show that after they were vented, they watched the vent times and lower GCS times, and that was shortened by multidose activated charcoal. So that's the only time I would consider it. And a lot of people like to throw that at extended release preparations such as calcium channel blockers. Just be aware that's actually not recommended and recommended against, because you do risk paralytic ileus and that hyperperfused gut, and putting a bunch of charcoal down there has been associated with significant poor outcomes. Next is a poison paper on urinary alkalization. As we know, anyone who treats salicylates, this is first-line therapy. I would recommend it sooner than later. The risk-benefit, the risk is low. The benefit can be a little higher. As we know, this is with an acidic drug such as salicylates with a pKa of 3. If you can alkalinize the substance it's in, it moves it to the ionized form and kind of traps it. So it traps it in the bloodstream, and then when it filters in the urine, it ionizes more, and it traps in there and gets it on out. And this is a good intermittent stage in a significantly poisoned patient before you get to hemodialysis. Speaking of hemodialysis, this is what I really want to share with you. I don't know if any of you know about this, the XTRIP, the Extracorporeal Treatments and Poisoning Work Group. This has been around about 3 years. All these you see here, these are the societies that have members that are represented, over 30 of them, including your ICU group here. This is clinical toxicologists, nephrologists, intensivists, emergency physicians, and pediatricians and clinical pharmacists who represent this group. They've gotten together and looked at actually what would be recommended for in hemodialysis in poisoned patients. Note that it's absolutely not recommended for TCAs. We know that. Carbamazepine is possibly suggested, but these are the ones they've looked at. This is the only ones. We're slowly working our way through the list, but of these ones I want to look at are paracetamol, lithium, and metformin. Many of you may not think of hemodialysis for paracetamol, but there is a subgroup that actually this can be beneficial. Paracetamol is a dialyzable drug. If you have a patient that presents usually a late paracetamol poisoning, they're altered, they're acidotic already with an elevated lactate. It's a big level, greater than 6,000. NAC's not going to do it. They should be considered for hemodialysis. That's an intermediate bridging. Maybe they get better, but if nothing else, they can prolong that time till the transplant's looked at and that process is undertaken. So if you have a significant huge paracetamol overdose. It's something to think about. Lithium's out there, often debated. There was a recent Cochrane collaboration for I don't know why they do it for toxicology, because there's no randomized controlled trials out there. As they state, we would know no evidence from randomized controlled trials to support or refute, so that helps us zero. The XTRIP group basically says if they're impaired kidney function with a level greater than 4, they should be considered for dialyze. And a lot of people say, well, how can you give us a number? The theory is we know the lithium's there. We know it's cleared by kidneys. If that's impaired, while it's in the bloodstream, that level, before it gets out and does its damage, you need to get it while you can. And that's why impaired kidney function, lithium greater than 4, should be strongly considered for dialysis. Or if they're altered or seizing or dysrhythmias, that's another indication. Metformin, we know metformin, significant overdoses, has a mortality of about 30%. Metformin should sit in the back of your mind to take a look at if you have a significant lactate greater than 20, severely acidotic, or they're shocked. You should consider these patients for hemodialysis. And all this is intermittent hemodialysis is the mode that's recommended. Valproic acid, that should ring a bell too if you get a significantly VPA overdose. I don't know why the question marks came up there, but greater than 9,000 is a pretty significant level, or shock or cerebral edema. Hemodialysis, again, should sit on the top of your list. So, in essence, just the takeaways: multidose activated charcoal for that comatose carbamazepine patient that's on your ICU can possibly shorten it. Don't do it if they haven't got a tube, because they're going to be altered, and the risks are great with putting a bunch of charcoal down. Urinary alkalization should be started early for significant salicylate poisonings. Even with a good history, you don't even have to wait on the level. Go ahead and start it. It can make a difference. It can prolong the need for dialysis. And the biggest thing is XTRIP. If you Google XTRIP, this is the first thing that comes up. And let me be clear, this is a huge consensus statement. After these statements are done, they're published in journals such as Critical Care, Clinical Toxicology, a lot of nephrology journals. And if you go to their website, what's neat is they do give you all the concise recommendations, but every paper that they've published in every journal is free to you or free to anyone through a PDF link there, so you can check it out for yourself. So this is kind of a big advancement in toxicology, and actually getting, rather than we suggest in these type of patients, more direct guidelines for hemodialysis in the poison patient. I think that's about it. Did I make it in 9 minutes? 7. 7. Ooh.